Speaker I would like to introduce is Dr. NEETHU Krishnan, who is also an assistant lecturer in KMCT Medical College, will be presenting the topic the blood eye. That means the management of traumatic hyphema.
Very good evening to all. So let us start with the bloody eye. Management pulse of traumatic hyphema. Okay. My presentations include what is hyphema, grades, complication and management. So first of all about the hyphema. What is hyphema? Blood in the anterior chamber. The causes include blunt injury, open globe injury, and source of bleeding can be occur from the peripheral iris, sphincter, and anterior ciliary body. The spontaneous hemorrhages can occur in cases of neovascularization of iris, vascular hematomas of iris, herpetic eye disease, retinoblastoma, sulcus IOL, coagulation disorders, leukemia. After intraocular surgery, the bleeding can occur from the granulation tissue and damaged uveal tissue. These are the spontaneous hemorrhages. Our topic is blunt trauma. So let us start with blunt trauma. Okay. In case of blunt trauma, there is first of all there is an anterior posterior compression, following which there is an equatorial expansion, which induces stress on the angle structures, resulting in rupture of iris stromal vessels and ciliary blood vessels, which resulting in hyphema. Okay. In case of lacerating injury, there is direct damage to the blood vessels, which resulting in hyphema, and along with the hypertony itself can result in rebleed and hemorrhages. The secondary hemorrhage or rebleed is occurred due to the clot lysis and retraction from the traumatized vessel, usually occur 2 to 5 days after the initial injury. So, with the history and examination, the case of trauma, we have to ask about how to trauma is occur, any possibility of intraocular foreign body, and along with the history like defective vision. In case of hyphema, patient may complaining of eye pain, nausea, photophobia, and vomiting. Along with, we have to ask the chances of coagulative disorders like sickle cell traits, because the complications and managements are different for these sickle cell traits. I will explain next slide. Okay. And there is need complete ocular examination, include intraocular pressure and dilate fundus examination is very important. And we also need to rule out the chances of ruptured globe, because along with the hyphema and subcongenital hemorrhage, there is chance to miss out the ruptured globe. So in case of occult rupture, there can be signs like low IOP, poor vision, deep anterior chamber, pupillary distortion. We have to rule out the occult rupture. Next, about the classification of hyphema, the grade 0 microscopic hyphema, which include only the RBCs, no layered hyphema, but RBCs itself can result in raised IOP and complications. Next, the grade hyphema, which include 1, 2, 3, grade 1, 2, 3, 4. The grade 1 is level of the hyphema less than the 1/3 of the anterior chamber. Grade 2 is 1/3 to half of the anterior chamber. Grade 3 is half to the less than the total hyphema. When the grades are increasing, the severity of hyphema and complications are increasing. So, in case of grade 4, there is total hyphema. It's also known as 8-ball hyphema, because it just appear like in a black or dull red appearance, like an 8-pool ball. It occurred due to the hypoxia and impaired aqueous circulation. The most complication that relate to grade 4 is the pupillary block and secondary angle closure glaucoma. Next, about the complications. The first of all about the raised IOP. The development and severity of glaucoma depend upon the amount and severity of hyphema. The other secondary glaucoma that related to hyphema or trauma is the angle recess glaucoma, ghost cell glaucoma, and hemocytic glaucoma and hemolytic glaucoma. The other complication that related to hyphema is the recurrent bleed and optic neuropathy, permanent visual loss, and corneal blood staining. I will explain. First of all, about the few words about the rebleed. Rebleed can occur in relation to hypertony. Hypertony itself can increase the chances of rebleed, and the rebleed usually occur after 3 to 7 days and due to the clot lysis and retraction from the traumatized vessel. And in case of rebleed, 50% cases can relate to secondary glaucoma and refractory glaucoma. In case of trauma or hyphema, we have to delay the gonioscopic examination to prevent the rebleed, usually done after 1 month. Another important complication is the corneal blood staining. The triad of hyphema, glaucoma, and endothelial damage increase the chance of corneal blood staining. In the IOP of 25 mm mercury, raised IOP more than 6 days can resulting in corneal blood staining. The pathology, the main pathology is in hyphema, the RBCs in the anterior chamber break down to hemoglobin. This penetrate the posterior stroma, and where it is hemoglobin break into hemosiderin, give an yellow granular appearance. So, it usually clear very slowly from the periphery, may occur as a permanent. In case of pediatric age group, one important complication that related to corneal blood staining is amblyopia, may be needed keratoplasty. And corneal blood staining can also mimic like a clear lens dislocation. And in case of hyphema, follow-up period, we have to assess the vision, hyphema status, intraocular pressure, corneal blood staining in every day for initial 4 days. After 1 month, we have to do the gonioscopic examination to rule out the angular recession, and retinal fundus examination also need to assess the retinal pathology. So let us start with the investigation. The routine blood investigation, along with the routine blood investigation, we can do anterior segment OCT. Anterior segment OCT is a non-contact procedure, so decrease the risk of rebleed. We can assess the anterior chamber depth, occult intraocular foreign body, and lens vault. And another one is the ultrasound biomicroscopy, which is given a good ciliary body visualization. So we can rule out the cyclodialysis, angular recess, and iridodialysis, and occult foreign body. Another one is the ultrasonography. In case of hyphema, there is hazy media, so fundus examination is very difficult. So we, with the ultrasonography, we can rule out the retinal detachment, intraocular foreign body, lens dislocation, and occult scleral perforation. So in our topic management, so start with management. We have to know the complication we already studied. So what are the complications? Raised IOP, glaucomatous optic atrophy, corneal blood staining, and secondary hemorrhage. So our management is prevent these complications. So initially we have to advise patient to bed rest and head elevation to settle down the hyphema or to decrease the chances of rebleed. And there is inflammation. We have to treat inflammation first. We can start with the topical corticosteroids, which act as an anti-inflammatory, along with it to prevent the rebleed. And cycloplegic can give and relieve the ciliary spasm and also decrease the iris movement. So another agent we can give the antifibrinolytic agents, which given prevent some amount of chance of rebleed, but no significant effect on visual outcome. It has its own systemic side effects. Next, our important part is to prevent the glaucoma or anti-glaucoma medication. We can give topical beta-adrenergic blockers, and topical adrenergic agonists can be given, especially in case of young children. But in case of sickle cell, it should be given in caution because it has an alpha-1 action also, can result in vasoconstriction. So in sickle disease, already systemically compromised circulation, along with the vasoconstriction, it increases the chance of optic damage. So in sickle cell trait, topical adrenergics are given in caution. Okay. And topical and oral carbohydrates can be given, but in case of sickle cell traits, which increase the anterior chamber acidosis, so resulting in more sickling, and complications are more in case of sickle cell. So we have to use it in caution. In all cases, prostaglandin analogs and pilocarpines are contraindicated because prostaglandin analogs increase the inflammation. Pilocarpines can result in peripheral anterior synechitis. So these are contraindicated in case of hyphema. Next important is corneal complication is the corneal blood staining. So to prevent corneal blood staining, we need surgical interventions. One of the indication for surgical intervention is the corneal blood staining. Clothes should be evacuated. And along with that, we can control the IOP. In pediatric age group, one of the complication is amblyopia. So we can do keratoplasty. Next about the surgical intervention, indications include uncontrolled glaucoma. First one is the uncontrolled glaucoma. Intraocular pressure more than 25 mm of mercury for 5 days with the total hyphema is one of the indication, and more than 35 mm of mercury for 7 days, and intraocular pressure more than 60 for 2 days to also indication for the surgical intervention. Any hyphema resolving less than 50% within 8 days also another indication, and total hyphema is more than 6 days also can result in severe optic nerve damage. So we need to surgical intervention. Another important point is I already explained, and the corneal blood staining is the one of the indication for the surgical interventions. And if the patient having glaucomatous optic neuropathy in fellow eye, we need surgical intervention. The surgical procedures are include are the paracentesis or release of blood through the limbal incision, and also irrigation and aspiration with the Simcoe's cannula or with bimanual irrigation aspiration probes. In case of organized hyphema, we are using anterior vitrector or Uthrata forceps. So a few words of sickle cell traits. Even small grades, even a low level of hyphema can result in severe intraocular pressure rise in sickle cell traits. So we can give anti-glaucoma medications, but and beta blockers are safe. Topical carbonyhydrates and alpha agonists are used in caution, and along with we can give transcorneal oxygen therapy. Thank you.
Thank you, Dr. NEETHU, for this informative